My name is Zinanani. This is my 1-month-old baby Chikonde. She is now growing and feeding well in the kangaroo mother care room. But she was born very early and very small, so she has spent the first month of her life here in this special ward, where the doctors and nurses are very experienced in looking after newborns. Very small babies like Chikonde are brought here because sometimes they need a bit of extra help to breathe, stay warm and feed. As mothers, we are the most important people in our babies' lives, and there are many things we can do to help them to get well and grow strong. But there are also things we need to learn about the ward. There are some simple rules which everyone, mothers, doctors and nurses, have to follow to protect the babies and to allow the doctors and nurses' work to go smoothly. Because they are small or weak, all the babies here are very vulnerable to germs. These are tiny particles, much too small to see, which can cause different illnesses. They can easily pass from person to person or from baby to baby. Many of the rules are designed to stop the babies from becoming infected with germs that may harm them. When you first arrive, you will find the ward has a closed door with a big line on the floor at the entrance. The line is to remind you that while babies are allowed to enter the ward, germs are not. So you must wash your hands using soap before crossing the line. This is very important. You will constantly see the nurses washing their hands or sanitizing them with alcohol. This is to prevent them moving germs from one baby to another. You will also be asked to take off your shoes, or you may be given other shoes to wear or covers to put over your own shoes. Before coming in, you must get permission from the nurses. If no one sees you, knock on the door until someone welcomes you in. They will find out where your baby is and take you there. If you have a cough or other infection, you may also be asked to wear a mask in the ward. When I first arrived on the ward, I was very frightened to see all of the machines with babies attached to tubes. The nurse took me to Chikonde. There was another nurse already with her. She was so small and seemed to be struggling to breathe. They told me that Chikonde only weighed 1.2 kilos, very small for a baby. They told me not to be frightened by the machines, that these would help Chikonde in her first weeks until she was able to breathe well and breastfeed by herself. As they worked, the nurses explained to me what they were doing. First of all, they used a small machine where they put a clip onto Chikonde's foot. It shone a red light. This is called a pulse oximeter. It allows the nurses to measure the amount of oxygen in the baby's blood. The nurses told me Chikonde's reading was too low. So they quickly put a little tube into each nostril called nasal prongs to give her extra oxygen. The nurses told me that the oxygen would not harm Chikonde at all. They put some drops into her nostrils, like teardrops, to stop them getting dry. Soon after that, they put Chikonde onto another machine to help her breathe, called CIFF, with a little head to keep the prongs in place. Because Chikonde was so small, she could not yet breastfeed properly. But the nurses told me that it was important for her to get some milk, as that is by far the best food for babies. So they put a tube into her mouth directly to her stomach. They then showed me how I could express some of my milk and feed it to Chikonde through the tube. I was a bit worried when they told me about this. But they said that without food, Chikonde would not be able to grow and would get very weak. The other thing they were worried about was that Chikonde may get cold. They put her into a cot with an overhead heater. They then attached a little wire thermometer or probe onto her stomach with tape. The probe constantly reads her temperature so that the machine could keep her warm but not too hot. For some time after the nurses left, I was able to sit with Chikonde, touching her and talking to her so that she would be comforted by my presence. This is very important for all babies. They need to be close to their mother. The nurses told me I'd have to come to the ward every 2 to 3 hours to feed Chikonde with expressed milk. I was shown how to wash my hands very well before expressing the milk or touching Chikonde so that I do not bring in germs from outside. The milk has everything that Chikonde needs to grow, and it also allows me to pass to her some of my own natural defenses against germs through my milk. So it is very important. When I came back to the ward, the doctor was there. She told me that Chikonde was slowly getting better. She explained more about the tubes and machines which were helping Chikonde to breathe. She said the CPAP machine pushes air and oxygen into Chikonde's lungs with a little bit of pressure. The oxygen is made by another machine on the floor called an oxygen concentrator. She said that the bottle on the CPAP machine should be bubbling, but for some reason it had stopped. The doctor took out the prongs and saw that one of Chikonde's nostrils was blocked. The air from the CPAP was not getting through. So to clean Chikonde's nose, the nurses brought a suction machine and put a tiny tube into Chikonde's nostrils to clean it out. They then put the prongs back. And this time the bottle on the CPAP started to bubble. The doctor told me I should let one of the nurses know if it stopped bubbling again. I was also told to watch and alert the nurses if Chikonde stopped breathing. This is called apnea and is very common with premature babies. If it happens, the nurses can do something to help the baby to start breathing again. The other thing the doctor was worried about was whether Chikonde was getting enough food to give her the energy she needs to breathe and stay warm. So they decided to give her some sugar or glucose directly into a vein. Chikonde already had a small device put into the vein on her arm called a cannula. When they put this in, she cried at first, but soon stopped. They were able to attach this to a machine which gave her a small amount of fluid and sugar continuously over 5 or 6 hours. For the first 2 weeks, Chikonde was kept in the first room in the ward, called the high dependency room. This is where most of the machines are. Almost all the babies here are very small and need help to breathe or stay warm. In the high dependency room, some babies are put into incubators. These are small beds with a clear hard plastic cover where the air can be kept moist and warm. Next to the high dependency room, there is an isolation room where babies who have an infection are looked after. Mothers who do not have babies in the isolation room are not allowed to go in, and there are strict rules about wearing masks and washing hands to stop the infections from spreading. Throughout the ward, you will see blue lights over some of the cots. This is to treat babies who get yellow skin and eyes, called jaundice. My friend in the next door cot had a baby with jaundice. She was very frightened. But the nurses reassured her that jaundice is common for premature babies, often developing a few days after birth. The nurses said the yellow color is in the blood, and it usually means that the liver is not yet working well. In small babies, especially if it is severe, jaundice can be very dangerous. It can cause damage to the brain, which can be long-lasting. Fortunately, there is a very effective and simple treatment. Placing the baby under a blue light, with as much of the skin exposed as is possible, breaks down the yellow color until the liver is working properly. The nurses covered the baby's eyes with a mask so that the blue light would not harm them. Sure enough, my friend's baby got better quickly. They were soon moved to another room on the ward called the low-risk room. This is an area where the nurses do not have to check on the babies constantly. After almost 10 days in the high dependency room on CPAP, Chikonde was finally breathing much better. She came off the machine and I was able to hold her for much longer periods of time. The nurses helped me to do that. As mothers, we want to hold our babies, but we need to ask the nurses first and get their guidance, because sometimes we can cause harm by picking them up in the wrong way. Chikonde's 2 grandmothers and my other children all came to the hospital because they wanted to visit and meet Chikonde. But the space in the ward is very limited and there are strict rules about visitors to stop infections being brought into the ward. So I had to tell them that they would need to wait until Chikonde grew stronger. They were disappointed but accepted it. Then finally, Chikonde was strong enough to move into the kangaroo mother care room, the last room on the ward. This is a much bigger space and family can also visit. Every mother has her own bed and a chair. It is called kangaroo mother care or KMC because they tie your baby onto you, skin to skin with a chitenje like a baby kangaroo. Babies like this. It keeps them warm and they feel safe. Other family members, grandmothers and fathers can also provide KMC. So Chikonde's grandmother was able to take over from me for some time, giving me time to rest. In some places, they are also teaching the mothers to do kangaroo mother care in the high dependency room, while the babies are still being helped by the machines. So now Chikonde is back home with me, where she stays in KMC position almost all the time. This keeps her warm. We keep her isolated from all her brothers and cousins so that she does not catch a cold or illness from them. She is still very small. But starting KMC in the hospital helped her to learn to breastfeed properly, and she is now growing very quickly. I hope you will also be able to take your baby home soon. For that to happen, it is good to listen to the advice of the doctors and nurses.